And in 3, 2, 1, here we go.
Good afternoon, everyone, and welcome to our latest series in the strategic webinar series with Transforming Chaplaincy and ACPE. My name is Geila Rajaee, and I'm your host today as we begin our presentation. And before we get started, I just want to give a couple quick highlights of some events that are coming up. One, we have the Certificate in Spiritual Care Management and Leadership, which is beginning at Rush. And so you should go ahead and check it out. I'll talk about it a little more at the end. And also, we have a couple spots left in the Chaplaincy Research Summer Institute. So get a chance to look at that and see if your calendars work to work with George Fitchett and Kate Peterman. Today's agenda, I'll be introducing our presenters and our respondent, and we have some folks from Baylor, Scott & White who will be talking about their program on sacred vocations, and an individual from Johns Hopkins University on resilience in stressful events, or RISE, the RISE program, and our response will be given from someone from Emory. We'll follow that up with a Q&A like we do generally in our sessions, and I ask that you go ahead and use the Q&A box, not the chat box, for questions. All of the recording and the slides will be posted after the session on the ACPE website, so you'll be able to find that information there in the future. So know that you'll be able to access this after the webinar is over. I want to get a chance to introduce all of our presenters today, and I'm going to start with our folks at Baylor, Scott & White. We have the privilege and honor of having the folks from Baylor. First, we have Reverend Mark Grace, who's the Chief Mission and Ministry Officer at Baylor, and Scott & White, and he is certified through ACPE and board certified through APC, and he is responsible for overseeing the pastoral care and chaplaincy programs there across all their facilities, and as well as programs that take employees and medical resources out into the community and out into the world to those who need it. He's joined with Chick Deegan, and she is the program manager for staff spiritual support at Baylor, Scott & White, and she manages the Sacred Vocations program. And having worked at multiple clinical specialties throughout her career, she has focused generally and broadly on organizational performance and transformational leadership development. From Johns Hopkins, we have Matt Norvell, who serves as a pediatric chaplain and the co-developer of the RISE program at Johns Hopkins Hospital in Baltimore, Maryland. To date, the Hopkins RISE peer support model is implemented to 20 institutions beyond Hopkins, and in addition to providing spiritual support to patients and family, Matt considers supporting and counseling staff as a vital responsibility. He's committed to providing patient safety and helping staff members deal with the stressors they face daily. And our respondent today is the Reverend Robin Brown Haithco, and she's the Director of Spiritual Health and Staff Support at Emory University Hospital. She is an ACPE supervisor, and she is also a former ACPE president. She's contributed to the book Professional, Spiritual, and Pastoral Care, a practical clergy and chaplain's handbook on spiritual staff care support. I know for myself, I'm really excited to have all of them with us today. As we think about this strategically, of what does it mean to pay attention to innovative staff support programs, I invite you to consider how many times you engage with individuals day in and day out, and whether that's clinical providers or also leaders who are worried and concerned about staff turnover, staff burnout, and the pain in which their staff is enduring. And so we begin today thinking about that in mind and the crisis of burnout within healthcare institutions across the United States and likely the world. And so I just thank all of our folks for being with us today, and we're going to get started because we have a pretty tight schedule. So starting from that, we're going to go with our folks from Baylor.
Hi, thanks for the opportunity, you all. My name's Mark Grace. I don't use the title Reverend that has to do with some personal issues. No offense taken. Call me chaplain or call me pastor. And if you want to know more about that, you can text me or something. About 12 or 13 years ago, one of our chaplains was pursuing a Doctor of Ministry degree at Bright Divinity School with TCU. She she is to this day an entrepreneur at heart, and began to do research. She said to me at the beginning, Mark, I just really, really want to do something that supports staff. And she found a program developed by a rabbi and an epidemiologist down in Houston, Texas, called Sacred Vocations, singular. And these folks had developed the program. I think it's fair to say it hadn't gone gangbusters there in Houston, but when Jennifer took this program on with the collaboration of the staff, we focused on patient aides and patient techs because their research showed those are the people who have the most face time with patients. And Chick is going to take you through that program, but Jennifer developed the program. We were fortunate to do some really in-depth research that was developed by a PhD student working with the epidemiologist. And so anyway, they developed it and found some really interesting things that Chick will talk about. It's been, when people come to me, especially administrative residents, and they say, what would you recommend after 35 years in healthcare, spiritual care? What's the one thing you would recommend? I always say to them, if it's possible at all, become a part of a movement. You don't have to start it, just get the experience of being inside a movement, because the flavor of the month, the repeating cycles of programs are really dispiriting. But what Sacred Vocation has been for us here for going on 12 years now is a movement that is transformative. And I'll let Chick talk about the rest of that.
Thank you, Mark. So I would like to share with you the conceptual model that the rabbi and the epidemiologist at UT Houston developed, and this is their conceptual model. And so it's really a partnership between the Sacred Vocation programmer staff, management, and the facilitators. And facilitators are critically important to this. And we have some wonderful chaplains who are facilitators. We've also had some contract community members, carefully selected, carefully developed, who are. And then through this experience, staff, management, chaplaincy, facilitators, and the participants move towards ongoing organizational change. And I just want to share a couple of the results from the research that Mark talked about. So in terms of the patient care experience and the pilot experience that was done as a research project, an IRB project, the patient experience, patient satisfaction was increased by 7% on the pilot units. In terms of work group performance, it decreased staff injuries by 42%. It decreased blocks to spirituality. This is our staff, even though we were founded as a Christian ministry of healing, staff didn't feel free to bring their wholeness into the workplace. So this decreased the blocks to that. It increased their mental health, and it increased mutual support and understanding, role to role and person to person, on the units and across units to improve communication. In terms of organizational performance, it increased retention on the pilot units a year after people graduated by 63%. And the return on investment is for every dollar invested, the organization recoups $5.86 worth of value. Much more value, but in terms of dollars and cents, that's what they recoup. And then in terms of potential community impact, first of all, this is all about life skills. This is not specifically a work skills, although we do focus on work. So our graduates take the personal transformation into their homes and into their communities. They also tend to participate more in our faith in action initiatives, And one of those ways is by going on mission trips where they are able to get a small scholarship to support that. So now I'd like to move on to what it is and what it isn't. So that would be the second slide. Thank you. So this is not a training. Lots of people when they come, and I think all of us in organizations are used to, if there's an issue that we want to improve, we put in training, assuming it's a skill knowledge deficit. This is very different. This is about from the heart, from the soul. It's bringing forth the best of who people are. So it's a reflective practice. And in the program, sacred vocation is defined as special work and a calling. And it emphasizes the capacity of every person to heal emotionally and spiritually or do harm, and we all do both. And the point is not to try and become any more perfectly human than we already are, but rather to become more conscious of situations that put us at risk for shifting from healing to harming, so we make better choices in the moment. And it's important to all of us at Baylor Scott and White Health that this be for those of all faiths and those of none, so it's very inclusive. And it is not religious. So some people come thinking it's going to be a Bible study or something similar to that, and it is not. It is more broad. It is about living a life of purpose and meaning and finding joy in your work and satisfaction. And it's the heart and soul of our Baylor Scott and White core commitment. And what I mean by that is we have a new visual, which you do not have. But it combines our mission, our strategies, our ambition, and our values. And each member of our Baylor Scott and White family have made a verbal commitment in terms of how they, in whatever role they're in, how they're going to support this. And this really, sacred vocation really translates or integrates from the words from the head to the whole person. Okay, thank you. So then I just want to show you the curriculum flow. So the way this works is it's usually 6 weeks, 90 minutes a week, although we are doing more sessions that are an hour each because of the realities of people's work and getting people off of the units. So week 1 would be about validating the human life. This is getting people back in touch with living a life of purpose and meaning, what's brought them to be who they are today, how they hope they're thought of today. And in fact, it takes them out to beginning to write their eulogy so that they can live more consciously into their day-to-day life so that they, at the end of life, or at any point along the way, they can say, yes, in fact, I am living my life of purpose and meaning. There is no disconnect. I am not living a life divided. Then we do a session on the capacity to heal and owning our capacity to harm. Role playing is very important. These are real situations, and Mark has just joined me in my office. So role playing is where everything comes together, and they actually role play situations that happen on the unit as first a harming situation, then as a healing situation. Then they create a healing oath. We'll see one of those in just a minute. And then they do graduation, celebration, where they talk about the impact of the program, what it has meant to them, and how they think it will impact on their lives and on their work. And their leaders are invited to come to that so that it begins to spread that energy. Okay, thank you. Then the healing oath is the next slide. This is just one example. So every cohort group of 6 to 12, or a few more who go through, do create their own healing oath. And this was one that one group did, just to give you an example. So 2 outputs of the Sacred Vocation program for the graduates are the healing oath and coping tips. And the coping tips are those things that they can do in the moment when they're in a difficult situation to get back on track as a healer. Okay, go to the next slide. Now, this is a slide that Mark is going to talk about, and now he's not in my office. So perhaps I'll start it. and hopefully he'll join in. So based on the experience over these 12 years, and we started with patient care techs and unit secretaries, and then we began to incorporate nurses. We did a pilot with nurses, and now it's sacred vocation for everyone. And then we've also adapted the program for leadership. So one of the really important things, and for you all, is the importance of the relationship and partnership between clinical leadership, administrative leadership, and chaplaincy. And that's where Mark has played a huge role. An important part for sustainability is to have leaders who are able to embed what they've learned from sacred vocation into how business is done to create the culture. Okay, Mark. Mark?
Hi. So I don't know what's been happening. I went down to Chick's office to see if I could see something that might help fix her sound. Sorry for that. So she asked me just to talk about the crucial role of leadership, and I'm going to try to do that briefly. The role of leaders has been important from the beginning. I will tell you, though, something that Chick may have already repeated. What made this program was the impact of patient aides and patient techs on the culture of their units. That's what got this started. And then nurses started saying, we want that. And then doctors started saying, we want that. Administrators. And so it's been really difficult. My passion has been, hey, let's keep this focused on the people who spend the most face time with patients and families. It was important. It's been difficult because everybody else wants in on it. And it was important from the beginning that we had visionaries like the president of our flagship hospital in North Texas, who just basically said, okay, he saw the first graduating class, and with all due respect to other religions, it was like a Holy Ghost revival. It was unbelievable. And he saw that, our chief nursing officer for the flagship hospital, and they just basically laid a blank check on the counter. Not quite, but in spirit, and said, hey, we'll do what it takes to keep this program going. And that has happened over and over and over again. Chris York, who's been the president in 2 of our hospitals, has made it his personal campaign to see that critical mass of employees in the hospitals that he is in do it. And that's a challenge, given that this is a voluntary thing. We don't conscript people into. So leaders build sustainability. They help to embed sacred vocation in the operational structure, and they give the needed energy to it, help us to get through the inevitable cycles, and communicate to their organizations that this is important. And they do that in practical ways by allowing people to take a work time, and they do it in intangible ways by stepping up and talking about the program. Okay, I'm going to stop right there.
We close. I just wanted to say that there is a short video, a 2-minute, 11-second video. You will receive the link so that you can watch this on your own. This is Chris York, the president that Mark was talking about the results and about creating a culture of love within the organization and the benefits of that. So I want to thank you for listening and appreciate being a part of this, and we'll move on to Matt.
Okay, friends. Let's see. I think I'm all set now. I am grateful for the opportunity to talk about our programs. I'm really honored to share this with our friends from Texas. It's a fantastic program that you've just shared with us. Our program at Johns Hopkins in Baltimore is called the RISE program, Resilience in Stressful Events. It's is the acronym. Whoops, I'm doing things quicker than I wanted to. It's a program that we started probably about 9 years ago, almost 9 years ago, in 2010. And I'm going to give you just a little bit of a history of kind of where it came from and how it's been implemented in our hospital and then other hospitals around the country. In 2000, actually even before, well, in 2000, my colleague here, Albert Wu, he wrote an article that was published in the BMJ titled Medical Error, the Second Victim, the Doctor Who Makes the Mistake Needs Help Too. He was a part of a medical error in his last year as a medical student in the early mid 80s. And then he noticed 15 years later that he was still carrying sort of the emotional burden or the emotional wound from his part in that error. And he realized he had never really gotten the emotional support that would have been helpful to him in that time. And so he wrote this article. It's a very short article, but it's made a big difference. In that article, he coined this term, the second victim. And the concept of the second victim, right? If I'm a nurse and I give the wrong medication, or if I'm a physician, I order too much medication or something, and a patient is harmed, then the first victim is the patient and their family. And the second victim is me as the provider, because I showed up to work today to help somebody, and I ended up hurting somebody. And so we started our program around this concept of the second victim. And you can imagine, it's not limited to somebody who's administering medication. There's lots of ways that in the course of care that people could hurt someone or maybe not help someone. And most care providers have pretty high standards for themselves. And so when they've not done just the right thing, people can take it out on themselves. But when there has been an error that people feel personally responsible for, they feel maybe they failed the patient, they question their own competence. I talk with a lot of nurses and physicians who will say, I have, maybe they're new to the field, and they'll say, I have a lot of loans, and I'm afraid that I entered the wrong vocation, and what am I supposed to do now? I can't earn money in any other way, right? You can see how it starts to shake people's kind of existential foundation sometimes. Another story that was really important to us as we were developing our program here in 2001, our own story. There was a young girl named Josie King who was burned in an accident at home, came and was one of our patients at the Johns Hopkins Children's Center. She was doing well, had healed from her burn, was being prepared to be discharged, and then sort of the holes of the Swiss cheese lined up, and some important test results were missed, and people didn't see what was necessary to be seen. She ended up decompensating really quickly and going to the ICU and dying. Her family quickly went to the press, went to the Baltimore Sun, which got picked up by the national press, said those nurses at Johns Hopkins killed my daughter. The family wrote a book. Her mother, Sorrel King, wrote a book. Book became a national bestseller. Got picked up. She went on Oprah. She went on the Today Show. Every time the story was told publicly, she said, those nurses at Johns Hopkins killed my daughter. Now, we did a really good job taking care of the family as best we could in that space, but then internally, we did a pretty poor job. We told our staff, don't talk about this. If the press calls, don't talk to them, but don't talk about it to each other. It's an ongoing investigation. Don't talk about it to each other. So the staff, especially the nursing staff, the physician staff that are involved in that, they got zero support. They didn't get any emotional support from the institution. And it caused a lot of ripples that we can still, every once in a while, I'll run into somebody in the hospital today that will say, you got to stop telling that story because it's not accurate, right? Like people have been hurt really significantly. And so one of my colleagues, there's three of us that have been working on this for a long time. Albert Wu, who I mentioned already, my other colleague who is a nurse, Cheryl Connors. She was actually a nurse on Josie's unit whenever Josie died. And she witnessed firsthand what it was like to have staff that ended up unsupported. And so, you know, you can imagine already what happens if you have, when you have medical staff, and it's providers of every level. It could be someone, as Chick was talking about, it could be someone who spends a lot of face time with patients and their families in a tech role. It could be a nurse. It could be the person who changes the trash bag in the room. It could be an attending physician. When somebody is a part of an event, and it doesn't have to be an error, but when somebody's a part of an event that is a really emotionally heavy event, and they don't get the emotional support that they need to kind of bleed off some of that energy, then it can lead to all sorts of dysfunctions, all sorts of problems, increased turnover, increased errors, people not, calling out, or people showing up whenever they're too stressed out to do good work. And so this, you can imagine a lot of just all of the troubles that can show up when we don't support our people who have been through some sort of a significant patient-related event. I think it was 1999, the To Err is Human report came out, and this was reaffirmed 2 years ago, 2016, that medical error is the third leading cause of death in the United States, at least, behind cancer and heart disease. It's dangerous to be a patient in the hospital. And so people are here, and just as a matter of course, we end up, errors happen. And whenever a nurse is a part of an error and decides to leave or doesn't do their job well, the cost to replace a nurse, and these are actually old numbers, right? That's 2009. Cost to replace a nurse, $22,000 to $64,000. Today, the number is a little bit closer to, it's almost a guaranteed $100,000 to replace a nurse, depending on where they work. Depending on a physician's specialty, it can be anywhere from $300,000, some quote up to $1 million to replace a physician. And so, institutions are super interested in anything that we can do to possibly reduce turnover even by 1 or 2 employees. And so with one of the gaps that was created that we knew existed is sometimes when people wanted to talk to somebody and they didn't necessarily want to talk to any of their peers, they didn't want to talk to somebody they knew, but they also, like if you called our EAP, if we called them right now, I'd probably have to get an appointment next week. I wouldn't have anybody that I could talk to right this second from an institutional perspective. And so this was an important gap that we recognized. And so we created this program we launched in 2011. We started in 2010, called RISE, Resilience in Stressful Events. And our promise to our people is that we provide timely peer support to employees who encounter a stressful patient-related event. Some of you have probably experienced psychological first aid, Red Cross disaster relief, kind of emotional first aid. What this is really is psychological first aid customized specifically for the medical environment. And so the promise, just to go through what our program does, we provide timely peer support. If someone calls, if they were a part of a really bad code, their favorite patient died, they ended up with vomit on their shoes, and they don't normally end up with vomit on their shoes in a day. If they want to talk to somebody before they leave today, we will respond to them and have somebody to be with them before they go home. We provide peer support. Whenever we started, we did a survey and asked people if you were a part of some sort of a stressful patient-related event, and if you were going to talk to somebody, because not everybody wants to talk to somebody here. Some folks have other great coping skills, but if you were going to talk to somebody, who would you want to talk to? They say, I want to talk to a clinical peer. I want to talk to somebody who understands the clinical environment. I don't need to start from zero. So, and that actually, when we look at those survey results, and we've done a lot of follow-up surveys in other places since then, it's consistently like 70% of people want to talk to a clinical peer, somebody who understands the environment. Second place after that is I want to talk to a manager or a supervisor. Third place after that is some sort of like non-clinical person, a spouse, a friend, a sister. And then in distant last actually is a combination of clergy, chaplain, therapist, mental health professional. Because most folks, right, if they have if we assume that they were resilient before and they encountered a really acute event today, and they need to process it, it's not like they have a new mental health problem. It's not like they've got a new spiritual problem necessarily. They just need somebody to process with, somebody else to talk to. So it's open to all of our employees. We kind of say anybody who wears a badge around here, from our security to, again, to anybody who's leaving a tray in a room, to cleaning a room, to providing medications. And it's to people who encounter a stressful patient-related event. We're pretty clear that we can't help people with HR problems. If they have employment problems, there's a structure for that of how to address employment problems. If they're having significant life problems with family or whatever outside of here, we'll kind of do an initial assessment with them, but we really encourage them to go to our EAP and seek therapy and professional help. What do we do? Provide a person to listen, supportive, attentive conversation, help to facilitate resources when somebody needs other resources. We have support available all the time, and we do one-on-one and we do groups. We are pretty clear with folks that we're not therapists, we're not counselors. The people that we train are, I can't remember if I have this on there. No, the people that we train are they're nurses and physicians and respiratory therapists who volunteer their time to be a part of our team. And we've developed a full day training and some follow-up training and sort of skill building to be able to help them learn to show up and listen and be supportive and not be judgmental. And if you all as chaplains looked at our curriculum, you would recognize it as sort of a distilled CPE, but a secularized distilled CPE. It's really, we train people to show up and be nice, and show up and be supportive and be a nice non-judgmental presence. This is just a part of the theory. This is based on actually, Sue Scott works at University of Missouri. They also have had a program for a long time, longer than us, and with a different model than we use. But the concept is people are resilient and they're hanging out in a resilient zone. Some sort of intrusive event happens, and then we have a RISE intervention, which is usually about a 30 to 45-minute conversation with somebody, which hopefully gives them enough space to be able to get back into a resilient zone so they can go back to their own normal coping skills. This has become really important for institutions. We're by the end of this summer, our sort of model of this program will be in 20 institutions beyond our own, from Baltimore to Saudi Arabia. It's 2 separate one-day trainings that are taught by our faculty, and we help to consult. It's distributed through, you can see this Maryland Patient Safety Center. I don't get any extra dollars for it, but we get to travel and meet cool people to do this. But the thing that has really gotten people's attention, especially sort of patient safety officers, directors of patient safety, last January, 15 months ago, the Joint Commission published this bulletin, and you can look it up, the Quick Safety Issue 39, about supporting second victims. They recognize that second victim phenomenon is a real thing, and that supporting them is really valuable, because this is both an anti-burnout intervention, and it's also it's a patient safety intervention. Because again, the thing that chaplains intuitively know is somebody who is living with chronic stress unsupported, who is living with acute stress unsupported, that doesn't help them make better decisions. It doesn't help them think better. It doesn't help them be better people in or outside of the hospital. And so since this has been published, and they referenced us as one of the model programs about how for hospitals to be able to build their programs on. And so that's gotten us a lot more attention, and we've been working as hard as we can to help support other programs in this. And then there's a few references. I'm going to turn it back to Geila, I think.
Fantastic. Thank you all for your presentations. And we're working through our technology for half a second. Now we're going to move to not quite a question and answer time, but a time where Robin will get a chance to respond to both the RISE program and the program at John Hopkins, so Hopkins and the Baylor Scott and White program. So Robin, I'd like to invite you to go ahead and share with us a little bit of your reflection from your perspective and experience working in this field.
Thank you, Geila, and thank you Mark and Chick and Matt. This has actually been really wonderful. Our hospital has been for the past probably 10 years trying to develop some programs that are going to support not only the culture within our organization, but also provide some support for our staff who are burning out. And we kind of know that by some of our nurses and our retention rate, folk who are coming in and they're leaving much earlier than we would like. And so this has been very, very helpful to me, and I hope it's been helpful to those who are watching as well. One of the things that I did know, there's a couple of things I wanted to note. First of all, I like the concept of sacred vocation. That is something that a language that I have been using in the past 13 years that I've been here at Emory. And so whenever I go out to do anything on compassion fatigue or empathic distress or moral distress, I basically begin with what called you into this profession? And most folks are like, what do you mean called? And I said, well, you know, that's kind of a spiritual term. I said, but there's something that pulled at your heart, something that kind of called to you to do this work of caring for suffering persons. And I said, I want to invite you to use that language and to think more about, as a nurse, this is your calling. As a physician, this is your calling. So, and that's how I tend to think of vocation, as kind of a calling. I like, Chick, your use of this is heart and soul work, and inviting staff to begin to look at the work that they do as sacred and holy. And if they look at that work as sacred and holy, then it invites them to embrace themselves in a way that's different. And the way in which they embrace themselves will impact the compassion and the care and the sensitivity that they bring into their work with colleagues and with patients and families. So I really do. And I think that what you all are trying to do, at least as I heard Mark, you and Chick talk, is you're talking about organizational change. You're talking about culture change, and helping people to kind of see themselves in the context in which they provide care for suffering persons in a particular way. And if we see ourselves as healers, if we see ourselves as called to the work of healing, not just for the patients and families, but also healing ourselves. If I can kind of borrow from Henry Allen, wounded healers, that we tend to go out and help folks to see ourselves in that particular light. What I saw with RISE, and I have to kind of give a plug here, because I'm hoping, Matt, that in the next couple of weeks, maybe couple of months, we're still working with our leadership, that we're going to invite you all to come down here and to help us develop a peer support program, because we are clear that our nurses and our physicians and other staff in our hospitals are looking for that. We have, you know, this hospital that I work in is pretty huge. We have a large number of staff. A lot of our staff, particularly in our critical units and our emergency departments, these folk are getting burned out day after day after day. They are trying to decide whether or not this is the work that they're supposed to be doing. And I think if we combine your two programs, Sacred Vocations and Resilience in Stressful Events, and create a peer support program, that would be the ideal within our hospital context. We're helping people to always remember, I've been called to this work. What's the passion that I had when I first came in, and how do I ignite again? And then helping us to help each other, I believe, in terms of support. Now, one of the things that I've heard, and I've heard this actually from our CPE folk, from our chaplains in the hospital, is we do a tremendous amount of work helping others to kind of ignite and renew and review their passion and their call for the work, helping them to get helping others to get support when they feel burned out. I wondered if either of you have done any work in relationship to how we care for each other, how we care for ourselves, those who are actually providing the care for our nurses and our physicians, et cetera, et cetera. I know my chaplains are asking me that question. So, Robin, what are you going to do for us? You're going out and doing all of this work for everyone else. So I think if I see the two programs that you all are involved in, one is looking at transformation, healing, and cultural change within an organization. The other is also doing the same, but looking at it in terms of how do we help our folk who are engaged in very stressful work. How do we help them to get the support that they need, to get it in an immediate fashion, to get it in a timely fashion, that they're not having to wait to go to an EAP program. They're not having to wait 2 weeks to get a de-stress or critical de-stressing done. But how do they get somebody that they can go to, and how do they trust those persons that they're coming to? That's how I'm kind of seeing your two programs. Actually, I want both at my hospital. So because I think both are needed, and our staff, probably the sacred vocations, that would be something. I was just talking to a colleague yesterday, because I'd gone through and I read you all stuff. I pulled off what you all are doing, Mark and Chick there in Dallas. That's tremendous work that you all are doing in the mission and ministry office. It's incredible work, incredible work. And I know a little bit from Matt. I'm excited to have them come to Atlanta, hopefully sometime in the fall, to do the training for the peer support program. And maybe we'll get you all to come as well, Mark and Chick, to talk to us about the Sacred Vocations program, how you got it developed. The key that you both talked about is getting buy-in from leadership, because this is not work you can do without money. We all need finances. I hope that you all can talk a little bit more about how you actually roped in leadership to get the support that you needed financially to continue these programs in your hospitals. Thank you, Geila. And thank you, Mark and Chick and Matt. I think now we can go to questions and answers, and Geila is going to facilitate that.
Absolutely. And we're going to take some questions, and I just want to, as folks are sending some in, I want to acknowledge that what I appreciate about these programs that you all have presented here is that they're really multi-level interventions, thinking about the individual and then also thinking about larger systemic. What does it mean as a chaplain to think about different ways in which we can make an intervention on an individual, upon a unit, upon the hospital itself, to help promote overall health and well-being. And I really appreciate the fact that what these programs do is that they're pretty similar and yet very different in the ways that they're solving problems. And that I think we all know that these sorts of problems are not going to be solved by just one solution, but will need multiple levels of impact. So one of the first questions actually came sort of focused, I think, to you, Mark and Chick. And the question was, how do you manage the time of your PTs and CNAs as they balance other responsibilities of their units?
So, so first of all, it is voluntary, as Mark said, and we need to have leadership support to get people to come. So it is paid time. It's coded as education time so that it does not hit the productivity of the unit for that manager. And we do it at times that are convenient. We set up our session times according to the unit or the hospital and the times that will work for them. And then we adapt to their needs. We're doing more and more 1-hour sessions, sometimes over lunch. And that seems to actually be working quite well. We're also testing. I've done my first group where I went to the first session and I'll go to the last session, and the middle sessions I did remote. I did through WebEx and or webinars with better sound than I had today. I apologize. Let me stop there. Did I answer the question fully?
That's good. I think there was a request to hear both of your responses, your different program responses, to some of Robin's reflections. And this time, Matt, would you be willing to start? And then Chick and Mark, will you follow?
Yeah, sure. I was just looking at the question specifically about leadership support and administrative support. By the time, so when we started, at our hospital, when we started, we had buy-in from the top down, because in our initial sort of work group, we had The person who was in line to become the head of patient safety for the hospital was there. We had the head risk manager in the room, and we had the person who was the vice president of medical affairs who became the president of the hospital. They were all present, and they understood it was a good idea, and so they understood the issue, the problem, and the solution from the ground up. And so they were happy to have us try and build it in-house. Now, the advantage of it, I mean, we didn't have any sort of a template to start with whenever we built, so we made it all up as we went along. So that was a disadvantage, but the advantage was you could just have all these people who were good people, and like most hospitals, they say, if you want to do some of this on your own time and sort of in between appointments, you're welcome to do it. And so we built it almost as a hobby. And so now, as we start to go to other hospitals, and it is a challenge to get, because our program does cost something for us to show up and teach it, and it's going to cost an institution something to pay somebody to run it once it's up and running, and so that takes some buy-in. There's no question about that. And usually it's patient safety officers, directors of patient safety, directors of risk that are really our primary connections, that are directors of nursing that get really interested in our program. But then once we show up, we do 2 one-day trainings, and the first day is really all aimed, we try to get as much administration in the room as we possibly can. And we set it up. I did a 15-minute version today. We do kind of a 6-hour version for the hospital administration and set up the problem. And really in the first hour and a half, we set up the problem, and here's a possible intervention. And every time you watch attending physicians, heads of hospitals kind of slap their forehead and say, oh my gosh, we've been ignoring these people. We've been firing these people. We've been investigating these people, and we've not been paying attention to their emotions. One hospital we were at, the guy at our first break, an hour and a half in on the day, he was the head physician for the hospital. He was sitting at a multidisciplinary table, and I heard him say, I wonder what my life would have been like if I had had somebody to talk to 40 years ago, and he started to tell the story of a patient that he thinks that he injured in his internship. And he says, I've never talked to anybody about this. I've been carrying this around ever since, right? And so people dig it once they get the idea, but you've got to get over that initial hump of helping them to buy into the idea. I've kind of joked recently that, again, we're all chaplains, so we can talk safely in this room, right? This is spiritual care intervention. This is teaching good listening skills. This is paying attention to people's emotions. But if I tried to sell it as a chaplain intervention, hospitals are not going to buy that and come institute it as a chaplain intervention. But it's shaped as a patient safety intervention. And hospitals are very interested in patient safety interventions. And so that's been the real benefit of the way that we've been able to get in with administration in different hospitals.
If I can say, Matt has presented one really important component. You don't move forward with system level or even entity level programs until you get buy-in from leadership. But with this program, what was fascinating to me with Sacred Vocation and other programs we've done is that our strategy has been to get permission to do the pilot or the prototype, and people have to see it working sometimes. And I think it's a mistake that a lot of chaplains make. They sort of think, I made this mistake multiple times early in my career, that they've got to go get the big kahuna. And I was lucky enough to get our CEO's permission for some really important, crucial projects early in my career. And then I watched them crash and burn because his number 2 was not in agreement. I watched them crash and burn because line management wasn't buying off on it. And so I've become a huge proponent of small beginnings. It doesn't mean that you shouldn't be. I'm not disagreeing with Matt. You've got to be talking to leaders, but you also have to be building prototypes that work and that demonstrate value. And once people begin to see that happening, they tend to get on board. The other thing I wanted to say, and I think it's maybe in agreement with you, Matt, if you compare the cost of these ventures to the typical cost of a program that they go buy off the shelf, HR is buying, it's unbelievable. I mean, I was blown away by the astronomical costs for programs that don't work, but the company is reputable, or the hospital thinks it's getting more because it's paying more, and that's one big advantage that I don't know about you, Matt, but I think Sacred Vocation really had, was that it cost about a tenth of what they were preparing to spend on employee engagement.
So,
Well, no.
if I could just make a couple comments to Robin, and what we have done, because of our CPE faculty seeing the benefit of Sacred Vocation, they've incorporated Sacred Vocation into their residency training, because it is different enough. Yes, they're very similar in terms of kind of the process and the content, but the safety that comes from the group being in the Sacred Vocation environment takes them to a deeper level, and they develop more of a sense of team and are able to better care for each other. The other point I want to make for anybody out there is that if you Google Sacred Vocation program, and that you'll get eventually to University of Texas in Houston, and on their website for Sacred Vocation, they now post their Sacred Vocation for Professionals manual online so that you can download that and implement on your own. They also have the Sacred Vocation for All, basically, that if you pay $50, you can download it. The other thing that I've done to the point of leadership, because we go from the individual transformation, Robin, you're right, it's an organizational transformation effort, a culture, potentially culture shaping. So one of the innovative things that I've done is to do an introduction to Sacred Vocation for leaders only. That's 2 1.5-hour sessions a week apart. That really is an abbreviated experience, but they get to experience it and benefit from it, believe it or not, in that short amount of time. And they also then understand how this is so different from a training that we spend oodles of money on. And then the results are sub-optimized sometimes because we haven't done the deeper heart and soul and purpose and meaning piece, which is so key to burnout, preventing burnout, helping people to heal and become resilient. So anyway, I'm going to stop there.
Awesome. We're gonna do some rapid fire questions with you all because we have a few minutes left to the top of the hour. One of the questions we have are, do the presenters see a difference in burnout versus moral injury, and are they the same or are they different from your perspectives?
I think of moral injury as a component of burnout. Burnout is kind of the big monster, and there's a bunch of things that help you get there.
I would agree. I think we have language of the month, and different people call different things different names, but they all come into or under an umbrella of burnout, compassion fatigue, whatever.
Are volunteers offered the support or training the same as paid employees?
Well, no, we have not. We have not gone into our volunteer population. We have gone into our physician population. We're beginning to do that. But we have not done volunteers. There's no reason why they couldn't. We do include our contract people like Aramark and other companies that are partners with us.
We do provide peer support to pastoral care volunteers. Yeah, that's a huge commitment of ours. Is if pastoral care volunteers find themselves in critical incidents, we make sure that they get care.
Do you all have any advice for a one-person department chaplain in a small community hospital getting anything like your programs going?
Build a machine. Don't go to work every day thinking that the only things that can get done have to be done by you. Build a comprehensive program of care that helps you to carve out time. I would say use volunteers. I make people really upset when I say that, but the right volunteers can help you build that machine. You can't do it by yourself.
And I would say, go find the poem, The Seven of Pentacles, and read it using the gardening metaphor for preparing the ground and multiple steps necessary, and then build on Mark's advice.
I have presented both to APC and to Healthcare Chaplaincy Network webinars on our program, and I title it Broadening the Reach of Spiritual Support, and talking about how, because our program is really ours a interdisciplinary. It's not owned by the chaplain department. It is co-owned by a couple of different departments. And so finding ways that you can essentially deputize other people who are already doing good work and help them maybe frame how they're doing the good work in a different way so that they're on your team and not just on their own team. I think that that's really good. And, you could use our program. There's a few articles that me and my team have written that you can find that talks about how we developed our program. There's nothing magic about it. You could do it on your own if you've got the bandwidth to do it. It's mainly an issue of time and will.
Another question for you guys, and that is, and you sort of touched on this, but have you all seen an increase in retention and participation because of these programs?
We have seen an increase in retention. I would say one caveat to that is if you have top leadership at a hospital, let's start at a hospital or a department, if you have leadership who is committed to building critical mass, and what that means to me is that they say, we really want to make this part of how we are and how we do our work. It's not about the what we do, it's the how we do it. And that they begin to get enough of their people to invited to experience this in a relatively short period of time, they're more likely to see the increase in retention than if you send 1 or 2 people every 3 months or something like that.
I think that your program there at Baylor got the best chance at influencing retention. We are emergency responders. We're not. You all are building ground level resilience, because we want to prove. I mean, in our hospital, our employee engagement scores have gone up every year since this program has been in existence, and I'd love to take credit for that. It was because of us, but we can't. If we're honest with ourselves, there's 1,000 programs that they're trying to implement around here of how do we keep employees and how do we keep them happier and how do we not make them leave. And so we have no proof that we're helping. Our program is helping. We wish, and this place is I'm going to work in a place that loves proof. We have no good proof that our program helps it.
I would sort of disagree with you, Matt, and I may be going way out on a limb here, but there is a body of literature focused mostly through critical incident stress management, so put aside the whatever, it's peer support.
Right.
And there is some evidence to suggest that yes, it contributes to retention. And
one of the questions on our employee engagement quiz that comes out every year is does somebody, I know that somebody at work cares about me, right? And there are times when somebody calls somebody from our team, and that's the only person that they know that's really cared about them, but then they feel like my institution has my back. So it's true.
Well, folks, I hate to cut us off. We have a bunch of really great questions still in that chat box, but it's 1:59 here in the Eastern Standard Time Zone, and we are at the end of our time. I want to just again briefly mention the Spiritual Care Management and Leadership Certificate that Rush is putting forward and invite folks to consider looking at that, especially as they think about how do I become a better, more strategic leader within my systems. And also the Chaplaincy Research Summer Institute. As a person who just completed an MPA and beginning my PhD, I think being able to really root yourself in some research literacy is crucial to being able to interface with different people within institutions and healthcare. But most importantly, I want to say thank you to our participants and to our respondents. Thank you for being here with us today and taking time to put your stuff together. I also want to say thank you to George Fitchett, who really is the one who really supports this program and makes it happen as well, and our folks at the Templeton Foundation, Transforming Chaplaincy, and ACPE, and the man behind the curtain, Carl, who is the one who really keeps this webinar together. So thank you to all of you for making this happen today. And we have another session that will be coming up, and that will be announced soon. We're just finalizing some details, but be sure to look on the ACPE website and the Transforming Chaplaincy newsletter for more information. With that, I'll sign off and say thank you to all of you for being with us today.
Thank you.
Thank you.
Bye. Carl, we're not live anymore, yeah?